Hello, folks, and welcome to our video on the cranial nerve examination. So this one is actually one of my favorites because it's pretty straightforward, because you sort of just think about what each nerve does. And so if you're familiar with what the cranial nerves are and what they do, then you'll be able to remember pretty much every element of this examination, or at least reason your way through roughly what we should be testing. So there's our overview of the cranial nerves. That's all covered in anatomy, so I'm not going to dwell on it. But we'll dive right into it and we'll go step by step. And each step I'll explain a little bit about how the signs that we're going to be looking at relate to the actual function of the nerve. So first of all, we're going to look at general inspection. So this is just some peripheral stuff we can pick up to begin with. So facial asymmetry is probably the biggest one. And so if somebody comes in and side of their face is drooping, there's really two main things we're concerned about. So facial nerve palsy, which we'll talk about a bit later, or stroke. Obviously, stroke is the red flag there. So it's important in that case, if you think there's a stroke, it can be good to rule out facial nerve palsy early on. Ptosis, so that's like the eyelid is drooping down, especially again if it's unilateral only on one side, and that might be an oculomotor nerve palsy. There's a few other things that can cause similar things, but in terms of cranial nerves, that's what we care about. Strabismus is basically just lazy eye or misaligned eyes, so patient's eyes aren't pointing in the same direction. We're going to be doing a more in-depth examination of that when we talk about that sort of group of motor nerves of the extraocular muscles. And so I won't dwell on it too long, but you can note it on general inspection if it's really obvious. And then hearing aids. So you have a vestibulocochlear nerve, all it does is hearing. And so if they've got hearing aids, it might be indicative of a cranial nerve 8 palsy. Same time, there are other forms of hearing loss, which we will talk about. So first of all, olfactory nerve, you don't test this. If you get into an OSCE room and they tell you to do a cranial nerve exam and they've got a bunch of smelling salts on the table, then maybe, I guess. But in practice, you don't. So you just say, I would like to test the olfactory nerve with some sort of smell sample. And then you don't do it because nobody has any of those on hand, even in hospital, unless you specifically get them. All right. So that said, the optic nerve is sort of the polar opposite because we test this a lot. In fact, between the optic nerve and the extraocular muscles, the eye stuff takes up about half of this exam's runtime. So we're going to run through each sort of bit in turn, and so hopefully you can see how they sort of all fit into a wider idea. So in terms of well, first of all, actually, I should clarify. Make sure in the bits of this where you test one eye, so pretty much anything between color vision and pupillary reflexes, all of those three in the middle, you want to really be assessing one eye at a time. So that means you get them to cover the other eye. Like you don't just keep both eyes open and then just look at the one eye. So in terms of visual acuity, so this is like how good your vision is basically in simple terms. And so you use Snellen charts. If you've ever been to the optometrist or the ophthalmologist, you remember those charts with all the letters that they get progressively smaller, you'd use one of those. So in practice, that plus Ishihara plates, which are those numbers with like the different the plates they have different numbers in red and green dots, and so if you're colorblind you can't see it. Both the Snellen charts and Ishihara plates, you mention them, so they're a keyword. You got to drop them during the exam and say, I'd like to assess visual acuity and color vision using Snellen charts and Ishihara plates. In practice, you wouldn't really do it. Just a bit of trivia on the side. So if your Snellen chart doesn't work, and so like they just can't even see any of the letters, you can then sort of go down the scale. So you go, okay, can you see how many fingers I'm holding up? And then if they can't do that, just say, can you see me moving my hand? So can they detect movement at all? And then you go down to light perception. So can they see light? And if they can't see light, then no point testing that. Now, so in terms of visual field and blind spots, so the reason it's a bit difficult to explain exactly what's going on in text form. So visual fields is basically saying, okay, so if they have vision loss, which they might not, you want to know where the vision loss is basically. And on the next slide, it'll be a sort of a map of how you can correlate that to where the lesion might be in terms of their nerves. But in simple terms, in terms of assessing it, so your setup for a single eye assessment is the same between your visual fields blind spot and really visual fields and blind spot are the ones that are set up pretty much exactly the same. So you sit down, you need to make sure you're parallel with the patient. You're both able to look at each other very comfortably. and then you cover one eye, you get the patient to cover the other eye. So like your right will be in facing their left. So you do that. And then you hold your finger up halfway between both of you. Okay. It's important that you're halfway between you guys, because what you're going to be doing is you're going to be comparing your vision to theirs. Okay. So you're sort of the benchmark in all of these tests. And so obviously not going to work if you have one of these visual losses, but the idea is if you can see it and they can't see it, we call that a deficit. So in terms of the visual fields, what we want to do is we want to do all 4 quadrants. So you'll set yourself up, you get your finger up, and then what you do is you sort of just do some sort of motion with your finger, something that they can see. And you start at the extreme of each quadrant and you sort of slowly move it in. And then you figure out, okay, I can see it now, all right, in the corner of my vision. And then you say, okay, can you see that? And they say no. Okay, you keep moving. And then maybe they see it around here. In some extreme cases, especially people who've had like neurosurgery or brain damage or brain tumors, they can have really stark stuff. So you can get all all the way here, and they just won't be able to see it. That might be a big extreme, like here, and they might not be able to see it because that quadrant is just gone. Blind spot is a similar setup. So again, you do your little thing. This time, you move in a flat plane. So your blind spot is not up and down. It's in the middle of your eye. So there's no point going up and down. And what you want to do is you want to go at a spot. It's maybe around there sort of. So it's about 10 degrees. A thing that people, I think, do often is they sort of go quite far out. It's not very far out. It's almost directly in front of you. But again, so it's the point at which things disappear. So tip of your finger might disappear. If you have a little hat pin, the hat pin tip will disappear. A thing that I forgot to mention with visual fields and that I should mention for both of them is that you always get them to focus on your nose. So they should be looking at your nose. You should be looking roughly at their nose because you want to be as aligned as possible. Yeah. And so if the blind spot is really just, is their blind spot bigger? So once you find the blind spot, you go up, down, left to right, and you're like, okay, well, is this a big blind spot? Is this a small blind spot? And that's useful for assessing central vision loss. So if they've got vision loss right at the around the sort of optic nerve region, then it'll make their blind spot bigger. Yeah. So accommodation reflex, this is basically your eye readjusting to focus on close things and far things. So what you do is, again, you ask them to cover one eye. You hold your finger near their face and you say, okay, look at something in the distance, far away. So you can point out something on the on the wall of the patient room, and then you tell them, okay, cool. Now look at my finger, and you watch their pupil while you do that. And so their pupil should change size as you move between those two things. If it doesn't, then there's maybe an issue there. And then pupillary reflexes are fun. So these guys is basically you shine a light and you see what happens to their pupils. And so the direct and consensual reflexes, again, make sure you, well, in this case, you don't cover the eye. Usually you just can put your hand in the middle to prevent light from leaking from one side to the other. But your direct reflex, so for example, if I'm going to test my, let's say I just want to test both of them in terms. So I might start with, okay, I shine the light in the right eye. I check the right eye. So that's the right direct reflex. So it's the reflex associated with the same eye. And then I'm going to check the left consensual. So I'm still shining the light in the right eye. This time I'm checking the left pupil. So if the left pupil constricts as well in response to the eye, and then that means that the left pupil consensual response is working. And then I do the same thing for the left side. So I try left direct and right consensual. And so that reflex is testing two nerves. So it's testing the optic nerve, and on the afferent side, relaying the information, and then the oculomotor nerve on the efferent side, because it's actually constricting the pupil. So it could be a deficit in either. Now, there's also a thing called the swinging light test, which we use to assess for relative afferent pupillary defect. And so it's important to understand how to interpret this one. So what you do is you swing the light from one eye to the other again and again and again, and you look at how the pupils constrict. And so in a normal setup, you'd expect to see the pupils constrict the same amount no matter which eye you shine the light into. If there's a difference, then it indicates, well, and mind you, if the difference is symmetrical, so a ocular motor nerve palsy might be asymmetrical, so you might expect to see, because it's the one that controls the actual iris. So if there's asymmetrical constriction, then maybe that's up. But if there's symmetrical constriction, but it's different depending on which eye you put it into, then that means that there must be a difference in how big the pupils are being told to be made, i.e., how much light the eye thinks is being sent. And so that means that there's a problem on the side where it doesn't properly constrict in the optic nerve. So in this case, when you shine into the left eye, the left optic nerve says, oh, wow, that's a lot of light. Let's close our pupils really tight. And then they both close really tight. Good. When you shine to the right eye, the right optic nerve is screwed and it can't really tell anything to constrict. And so the left eye doesn't constrict either, because the left eye hasn't got any information suggesting that it should constrict. Whereas when we shine it into the left eye, the afferent information came in and told both the left and right pupils to constrict. So hopefully that makes sense. And there you go. You now know how to screen for relative afferent pupillary defect. And this is talking a little bit about the interpretation of those visual fields we talked about. And you might have already seen something like this at some point, but the basic idea is that as we go through the anatomy of the eye, we can really see, based on the visual fields, where the lesion is going to be. So the ones that really pop up often are your bitemporal hemianopia. So that's going to be, well, like in your classic buzzwordy sense, it's going to be like a pituitary adenoma or something that's sitting there in the optic chiasm, presses on the optic nerves, and it causes vision loss out to both sides. If you get a homonymous hemianopia, so that means that they're both on the same side, so you've lost all your right-sided vision instead of your right of your right eye and your left of your left eye, and that means that it's now in the actual optic tracts. So as a general rule, anything that has the vision loss on the same side of both eyes is happening posterior to the optic chiasm, i.e. the crossover point. Yeah, and of course, if it's correlated based on just the eye, so the entire eye is gone, the other eye is fine, then that means it's before any crossover happens at all. Easy. Okay, so 3, 4, and 6, these are all our extraocular muscles. And so the way we do it is we do typically the double H test. So what you do in that is you go up, down, obviously get them to watch your finger, into the middle, to the side, then up, down, other side, up and down. Or you can start, it doesn't really matter where you start, as long as you do the whole double H thing. The idea with the double H is to try and lock out the muscles individually, so you can assess them one by one. So you can see in the little labels here which muscles in particular we're trying to assess. So in terms of what happens when things are wrong, cranial nerve 3, your oculomotor nerve, supplies almost everything except for the stuff that pushes the eye down and pushes the eye to the side. So obviously, if you have defects in cranial nerve 3, then those two, the 4 and 6 cranial nerves are going to be the only ones that do anything, and that means that you're going to get a bias towards those muscles. So out for the abducens and then down from the trochlea. And then, so 4 by the same token, since it's the one that moves the eye down, it's going to, when there's something wrong with it, when you try to adduct, the eye, you get a deviation upwards of the eye because there's not enough force downwards. And then if there's a issue with cranial nerve 6, the abducens nerve, shockingly, it means that you can't abduct the affected eye. While we're doing this, we also want to have a look at again strabismus, but this is basically what we've been talking about. So these defects will most likely be unilateral. So one eye will do the deviating upward thing or be unable to abduct. Your patient will get double vision because obviously they're seeing 2 different things. And then you can also get nystagmus. So that's basically like you move your hand very smoothly and the eye sort of just jerks like bit by bit. Obviously the head's not going to do that, but you get the idea. And so those are things that you need to report. All right. So the trigeminal, this guy has a lot of different things that it does, and so we're going to assess it in a few different ways. So the sensory component is basically the face. So you might remember that little map that we showed you a while ago about the cranial nerves of like, here's where the trigeminal innervates. So you want to test each of those separate divisions. And what you do is you get them to close their eyes. Again, so always get them to close their eyes when you're testing sensory information, because some patients, they would literally just look at you, you know, touching their wrist or their leg or something. They feel nothing, and they're like, yeah, I felt that. So you close their eyes, and then that gives you a more fair test. And so you usually what you'll do is you tap the forehead, you'll tap sort of this region, I guess maxillary region, and then your jaw. And so that hits your three sort of different stretches of skin separately. The motor component, so what is the trigeminal innervate? The muscles of mastication. And so what you'll do is you'll palpate the muscles and you get them to clench their jaw tightly. And then if you feel that there's some muscle bulk there, then that's A, it helps you assess function, and B, also, very importantly, helps you assess symmetricity. So it's hard to just decide, okay, you have like good masseters or bad masseters. But what you can say is, okay, you have a bigger masseter on the left side. What does that mean? Or you have a weaker masseter on the right side. What does that mean? In terms of reflexes, you don't really do these very commonly in practice. So your jaw jerk is like you get them to move their mouth open slightly, and then you tap it downwards, and then it's meant to go up a little bit. But in abnormal patients, it can go the whole way. I can't say I've ever seen it or been asked to do it. Corneal, you definitely don't really do it in an OSCE because it's touching their eye with cotton wool, which is not something that Monash cares enough to do. Yeah. Okay, so the facial nerve is an interesting one. Like I said before, we have a very famous type of palsy called the Bell's palsy, where you get one-sided facial paralysis. So this guy's paralyzed on his right side. So he's currently trying to smile. His left side is doing fine. His right side is not pulling its weight, and so everything sort of looks wonky. So in terms of the movements we do, there are 4 ones that we typically go with. So one is the raise the eyebrows. And that should wrinkle the forehead. If it doesn't wrinkle the forehead, then that's concerning for a stroke, because it means, sorry, no, hold on. If it doesn't wrinkle the forehead and it's also positive for all the rest of them, so you don't get any movement, then that's suggestive of a Bell's palsy. If if you're unable to close your eyes tightly, puff out your cheeks and smile, but you are able to raise your eyebrows, then it might be suggestive of a stroke. Yeah, I always like to try and slip the smile widely in a while. Like the patients love that because you're sitting there making them sit through a half-hour cranial nerve exam. So please try and do it. Yeah. Okay, so vestibulocochlear, this is our hearing. So everything, really, what this is a hearing test, is what this part of the exam is. So obviously, first of all, ask there are any problems with your hearing, anything has changed recently, and then you can try and localize where any hearing loss might occur. So there's 2 types of tests that we talk about called the Weber and the Rins test. We'll talk about Weber first because it's a more simple one. You just set your tuning fork going and you sort of plop it in the head like a unicorn horn. And then we need to talk about the 2 types of hearing loss that can happen. And so we have the sensorineural one, which is an actual nerve injury, and so that's what we're looking for in this exam. And then we have conductive hearing loss, which is basically like your ear canal is just blocked up, straight up. And so if you get if you do a sensorineural if you have sensorineural hearing loss and you do the Weber test, the patient feels it more on the side that's normal, because of course they do, because that's the side that's still transmitting stuff through a normal nerve. If they get conductive hearing loss, then the sound travels better through vibration than through the ear, and so it actually is heard louder in the affected ear than in the normal ear, if they do in fact have conductive hearing loss. Then there's the probably just RIN, I don't know how to pronounce it, test. And so that is basically trying to figure out if the sound is being transmitted better through the air or through the bone. So if it is transmitted better through the air, which is normal, then that might be sensorineural hearing loss. But really the usefulness of this test is in when you get bone is better than air. So you yeah, actually, I should say how you do these. So you get your tuning fork going, and then you hold it near their head, and then when they can't hear it anymore, well, you hold it near their ear. When they can't hear it anymore, you press it to their sort of as far as I can remember, their mastoid region, or might actually be in front of the ear. I'm not entirely sure. I'm not sure if it matters either. But you stick it there and you say, okay, can you feel that? Or can you hear that rather? And if they can hear that, then that might indicate a conductive hearing loss, because again, it's all about sound propagating better through solid objects. But yeah. Okay. These guys are, we can sort of group them all together because it's all just tongue stuff, well, like pharynx stuff, really. So you get them to open their mouth, stick out their tongue, and then you look at their tongue and the uvula. So the tongue is a marker for your hypoglossal nerve palsy, and it goes towards the lesion. And the way you can sort of understand it is with the tongue, when you ask them to stick their tongue out, it's like there's muscles, those muscles inside there are trying to pull the tongue out / push it out. So if you have two sides and one is not doing very well and the other one's doing great and it goes ahead, then you can see how the whole thing sort of ends up turning a little bit. And that's exactly what happens with your tongue. So the affected side doesn't do very much, other side goes, and then you turn towards the affected side. The uvula is the opposite thing. So both sides are trying to pull the uvula to their side. So if there's a problem, then that side loses, and then the normal side gets the uvula. So the uvula goes away from the lesion, whereas the tongue goes towards the lesion. Yeah. And so the vagus nerve, theoretically, it's half of the gag reflex. So the afferent side is the glossopharyngeal nerve, and then the efferent side is the vagus nerve. In practice, you don't test this because, like you say, I'd like to test gag reflex, and you don't actually do it because it's just very uncomfortable for the patient. Yep. All right, and finally, lucky last, accessory nerve. And so this one is dead simple because unlike all the other cranial nerves, it's a little undercover fake. And so it just innervates our back muscles. And so the trapezius muscle is a big one that is probably the easiest to actually control. And so it is most obvious to test and most closely linked to the accessory nerve. And so you put your hands on their shoulders, you get them to shrug up, and if they are weak or they can't do it, as opposed to as compared to their baseline, then maybe they have an accessory nerve palsy. So yeah, that's pretty much all of them. I'm just trying to remember if I've forgotten anything. I think that should all be pretty straightforward, hopefully. But yeah, if you have any questions, feel free to message me. Otherwise, hopefully this gives you a pretty good idea. Oh, I did want to mention, sorry. So with ptosis, your eyebrow drooping, you might be thinking back to our lesson on sort of like facial anatomy and all of the stuff that we put out regarding that. And you might think, okay, well, hold on. Your orbicularis oculus, I think, that's all facial nerve stuff. So why does ptosis have anything to do with the oculomotor nerve? And what it actually means is that the levator palpebrae superioris, so your superior opening of eyebrows, pretty much of eyelids, sorry, that's innervated by the oculomotor nerve. And so if that doesn't work, then your little lifter doesn't work, and then the whole thing falls apart. So yeah, hopefully that was helpful. Message me if you have any questions about the cranial nerve exam, but hopefully I think that should give you guys some stuff to go on. Have a great day, and see you next week.